the drugs used in migraine. So guys, in migraine patient we use the drugs for two purposes. One is terminating the acute attack, and second is decreasing the frequency of headache, decreasing the frequency of migraine attack, or you can say the headache. So these are used for treatment and these are the drugs for prophylaxis. So prophylaxis means drugs decrease the frequency and treatment means terminating the acute attack. So what are the drugs for terminating the acute attack first? So the drugs which are terminating the acute attack of migraine, these drugs are divided into three categories. One is non-steroidal anti-inflammatory drugs, NSAIDs. In NSAIDs, like we use the drugs paracetamol, we can use the naproxen. So these drugs are NSAIDs. We'll discuss. These drugs are used in the patients who have the mild headache. So in the mild headache, these drugs are best. No need to give the unnecessary triptans and ergots. You can use the NSAIDs. After this, guys, we have the ergot compound, ergot alkaloid, and we have the triptans, ergot alkaloids and triptans. Ergot alkaloids and triptans, these are used for moderate to severe. These are used for moderate to severe headache. So in mild, no need to give the ergot or triptans. So guys, what is the difference in the ergot alkaloids and triptans? That is important. So the difference between ergot and triptans. The difference between ergot and triptans. In ergot and triptans, what is the difference? These ergot compounds are natural. These triptans are synthetic. Natural and synthetic. And I told you the difference between natural and synthetic because these are natural, they are not selective. These are non-selective. But these triptans are selective. Selective at 5-HT1B, 1D. 5-HT1B, 1D agonist. These are non-selective, they have the effect on 5-HT2. They have the effect on alpha. So they are 5-HT2 antagonist, alpha blockers. They have the effect on dopamine. So non-selective, they are not selective for one receptor. After this, guys, there is risk of, with ergot compounds, there is risk of. So what is the risk? It increases the nausea and vomiting. Triptans do not increase the risk of nausea, vomiting. And there is risk of end arteries vasoconstriction. And there is risk of end arteries vasoconstriction. In this, there is no risk of end arteries vasoconstriction. Because of end arteries vasoconstriction, there is risk of dry gangrene. There is risk of dry gangrene at the tip of finger, tip of toes. There is risk of cyanosis, claudication. So basically, you can see the ischemic pain, cyanosis, dry gangrene. These risks are there with the ergot compounds. These risks are not seen with the triptans. So that is why triptans are the best drug. So what are the ergots? So in this, guys, what is the example? The example we use for migraine is the ergotamine and dihydroergotamine. Ergotamine and dihydroergotamine. These are the drugs which are used for migraine patient out of these. And guys, remember these drugs, ergotamine or dihydroergotamine, these drugs can be used or they are available. They are used and they are available with caffeine in combination. So what is the advantage of this caffeine? Caffeine itself vasoconstriction. So cerebral vasoconstriction will be there. So that is the advantage. As well as caffeine increase the bioavailability of ergot compounds. The main reason is not known till date, but they definitely increase the bioavailability. It have been proved by the different studies. So that is why available with the caffeine. So ergot plus caffeine is commonly used in the migraine patients. Then guys, some newer drugs are also available. Some newer drugs for terminating the migraine headache. In newer drugs for terminating the migraine headache, one important is we have the meditans. So one important is meditan, that is 5-HT1F agonist. 5-HT1F agonist like less meditan. So this less meditan is 5-HT1F agonist. So that is also on the serotonin receptor. And guys, the recent studies believes that this migraine is because of the calcitonin gene related peptide CGRP. So calcitonin gene related peptide is responsible for this migraine headache, and that is the important part of pathophysiology nowadays. So because of that, now we have the drug which are acting on the CGRP. Even the newer studies says that these triptans, these meditans, these are also acting via CGRP. They have the serotonin receptor acting drug, but they are acting through the CGRP, calcitonin gene related peptide. So guys, we have the GPENTs. These GPENTs are CGRP. So these drugs are like olsegepent, ubrogepant. So basically these are gepent. So these are calcitonin gene related peptide stimulator, CGRP agonist. So olsegepant. So these are some newer drugs which have been approved for acute migraine headache. After that, we have the drugs for prophylaxis of migraine. The drugs for prophylaxis of migraine. So guys, the drugs for prophylaxis of migraine, in this we need to remember that the overall best drug is beta blockers. So beta blockers are the drug of choice. Example is propranolol. It is the overall best drug. Then guys, we have the calcium channel blockers. In calcium channel blocker, the important drug is flunarizine. But diltiazem, verapamil, these drugs can also be used, but main drug is flunarizine. Don't use the nifedipine, amlodipine like drug. They can cause worsening of condition because they are vasodilator. Then guys, we have the drugs like tricyclic antidepressants. In this we have the amitriptyline, nortriptyline like drug. These drugs are also having the important role. Then guys, anti-epileptics. In out of these anti-epileptics, the drugs which are used in migraine, the important is valproate, topiramate, gabapentin. These drugs are having role in the migraine patients. So gabapentin, valproate, out of these anti-epileptics, valproate, topiramate, gabapentin, these drugs can be used for migraine. Then guys, we have the angiotensin receptor blockers. Out of these, candesartan, it is having role in migraine patients. And we have already discussed the drug which are acting on 5-HT2 serotonin receptor. So 5-HT2 antagonist. In that, as I told you, we have the cyproheptadine, we have the methysergide. So these drugs, I told you, these drugs can also be used for migraine patients. So that is the list of drugs which are used for migraine prophylaxis. Out of these, the very important drug is beta blocker, then flunarizine, amitriptyline and valproate. These are commonly used drugs, but we have the other drugs also, and out of this, candesartan is commonly asked nowadays, that which ARB is used in migraine prophylaxis, that is candesartan. Now guys, in this also we have some newer drug, and that newer drug in chronic or prophylaxis of migraine is, this is important, these are the monoclonal antibodies. So guys, these monoclonal antibodies are targeting the nervous system. So the important monoclonal antibody for migraine prophylaxis is like fremanizumab. So you can see NE, nervous system, monoclonal antibodies, humanized and nervous system, fremanizumab. Erinumab, so again nervous system. So guys, these antibodies are there. Which are approved for migraine prophylaxis. Other than these monoclonal antibodies, we also have the onabotulinum toxin. I told you, if you remember, onabotulinum toxin. It is also approved for migraine prophylaxis. It can be given local injection in the scalp. So that is also used for migraine prophylaxis or tension headache. So these are the drugs used for migraine prophylaxis. So in the acute attack, triptans is still best, and in the prophylaxis, beta blockers are best. So that is about the drugs for migraine therapy.